Apologies, I'm so sorry.
Depending on the circumstances they were born with or born into or currently live with, face different circumstances to be able to live their healthiest and best lives, and our commitment to trying to ensure that they are able to live that life and also face different barriers to being able to live. Those barriers may be systemic, environmental, and come in a myriad of different forms that are, let's say, different heights for different people. That's why you sometimes hear folks try to make a distinction between equality and equity. I tend to think of them sometimes as the same thing, but people essentially don't want folks to think you can give the same solution to everyone, because it won't solve that problem for everyone, right? You need to provide folks with what they need, depending on where they are, and to allow them to be healthy. I know that sounds kind of vague, but for example, if I have multiple health conditions, I come from a demographic group that is traditionally, been discriminated against, or is at a higher risk for certain conditions, I'm going to need a high level of care and additional supports than someone who does not face those same level of barriers. And it's trying to come from that framework and build plans that both allow us to identify those specific set of needs and allow us to provide those level of supports for these.
That's a great way to begin, and I know other folks have other thinking about this. And does someone want to chime in, or do I just call on someone I've spoken with who's very thoughtful about this? Ali, do you want to say something about all of this from your perspective and your hard work?
I think as I was sharing with you, and good morning, my name is Ali Sekou, and I am working with New Hampshire Housing Financial Authority as the Director, Manager of Community Engagement and Inclusion. I think I don't have much to add other than what Ruben said. What equity means to you might be different than to me and to others. And we see some polarization around what equity means. People think it's taking access from the people that it's already existing in. That's not the definition of equity. All this is politics. And I myself am in politics in some ways because people consider somebody who is elected in office is in office. I'm a city councilor of Concord here, and I will tell you guys that equity has nothing to do with race or anything. We have poor white people. We have white people that are struggling on a daily basis. So people that are using that to say, let's eliminate this or let's do this, I think it's a misunderstanding of the topic of equity itself. Just saying, let's give people access. Because we have seen what affected China affected us more. I'm talking about coronavirus. And when it comes to health, there's no joke around it. Because what affects your community today can affect anybody in the community. More people died here of COVID in America than it has done in China where it started. And it's all due to our politics and our misunderstanding of things. And health has no barriers when it comes to race or gender or age. We have people here in our community that cannot even get a healthcare provider. You have to know somebody, or you have to be with somebody, or it's just too complicated. And the issues are real. Some people are struggling, and it has nothing to do with the race. I have no problem, and I'm Black, and I'm immigrant. But not everybody has the same opportunity as Ali. And this is where we, as the humanity, as the leader of the community, and as professionals and experts, should put our heads together and to say, hey guys, let that division go, and let's look at the reality of things. In a health perspective. And if somebody is asking it for free, it's different. But that's not the case. But the reality is, we have even seen recently, there's already bills out there. Let's eliminate the Department of Health, equity, let's do this. For what reason? And the community will sit behind and cross their hands and thinking that, okay, it's the best option. Until somebody travels somewhere and brings something here and you affect all the community, and now we try to run around to say, what? Because it'll affect everybody. So my ask here, I was in the northern New Hampshire and Dover yesterday, no, Saturday. And somebody who worked at the hospital said, is this team that we are all, as they said, selected to be on for any given reason, we have to take this responsibility seriously in the term of knowing that we have that capacity and that responsibility to do what they ask us to do, to report what we see. And the person said to me, is this team going to listen to what like the northern country and southern, and I think she said there is 6 health center, yes, something like that. And she said, some of them are very independent, has nothing to do with others. Why can't we not bring all of them together and listen to them? Because what is affecting the northern country might not affect us here in some aspect due to the resources available in town. I'm like, what? So then bring it to the team, and I'm newly appointed to this team. But I don't want to take much time. I just want all of us to be the ambassador of this work in our respective communities. And to take this responsibility seriously. And to know that whatever affects your community member will affect you when it comes to health.
That is real, that is very, very helpful. We have wonderful comments in the chat on this, but if anyone have a reaction because of the scope of equity really, I think, helps sometimes when the views are different. So I don't know if anyone wants to respond to Ali's, and then I want to move on to some of the comments here.
Just well said. Okay.
As I said, it's personal. We have the president of the Islamic Society of Greater Concord here, and I am an immigrant myself, and I see it every single day, and a proud American. So anything that goes in affects me. I'm raising 2 beautiful children in this community, so I'm not taking this lightly.
Okay. I think you're right. When you look at the equity, you have to look at the various regions of the state, because what you experience in Concord will be different than what we may experience, less densely populated rural North Country. We're the second oldest, fastest aging state. Maine is the oldest, fastest aging. And the North Country is the oldest, fastest aging region in the state. So some of the challenges we may face may be more associated with equity and aging than you might experience in Concord. So that the solutions, I think, are probably going to come closer to people who experience the inequities. And I think, to your point, that's that listening of at that hyper local level, because some of them have ideas of how to resolve equity, and the conversation probably has tones of inequities in it without explicitly calling it inequity. If I can't get transportation to get to the VA, I live in Colville. That implicit in that is inequity, that someone else is able to get there. So I think that just exemplifies that the importance is, as I told friends, I said, in some senses, we become acolytes of the ship to have to take it out into the communities and have those conversations and engage people in action to work with them to help resolve those inequities in that town, which might be different than in this other town.
I want to give Bobby a chance to say more about what she has written in the chat, and then I want to talk about special populations as Ed has, a mention which has come up consistently and came up in the homework that folks are working on.
And I believe at some point Andy had a hand up. so
Andy
It makes sense
too.
to go to Bobby first.
Bobby, because she's been in here, and then we'll go to Andy. I apologize.
Yes, thank you, Palmyra. So, in listening to, I think you said your name was Ali?
Yes, correct.
Ali, and listening to Ali, and then looking at the definition that we have as a working definition, it's a both and, right? And so there are inequities that exist because of race. There are inequities that exist because of um, gender, disabilities. They exist. It's just a part of our uh, social makeup. And so when we look at tackling or addressing equity, we have to think about the approach that we take, from a population-based level, and then sometimes even down to the individual levels, And so in the work that, we've been able to do here, I forgot, Bobby Bagley, Health Department, City of Nashville, we were supposed to say all that stuff. And so at the level that we do, we take a population-based approach, and what we will see is that there are inequities that exist because of certain social factors that individual finds themselves in, just as Ruben discussed in defining the definition of equity. And so it's a both and. We may have to take into consideration, does this inequity exist because of this particular social factor or this particular determinant that this individual, that this community, or that this population has for them? And our definition that we have, a particular population that we've been working with for a couple of years now, has been the homeless population. Now, that's a very diverse population of individuals across different ages, different race and ethnicities. But there are some inequities that exist just because they're homeless, right? Or they're experiencing homelessness. So that's a social factor that exists where we're running into a lot of barriers just because that population is homeless. We're saying the same thing with individuals who are experiencing social isolation. There are inequities that exist just because of that social factor. So I think we have to, as we're doing this work, take in consideration those things, and then address when we know inequities exist because of racism. Then we need to address what training, what types of information, what type of awareness needs to be put out there so that we can close that gap or that barrier, because it still exists. So I'm sorry. So Ali, I'm gonna nicely disagree with your comment about it's not about racism and not about those things, but I mean race and ethnicity, because I see that that does exist in the community here, and it may not be in some other communities. And so we have to take it from that standpoint. Thank you.
Thank you, and I think you summarized it very well. What I was saying is like, I never disagree with that. Did you hear me saying I'm a Black man, an immigrant? Racism is never taken out of that comment. I'm just saying that when we talk about equity, we look at the lenses of equity in general. And you did support that idea because you talk about homelessness. Homelessness has a race. How many people are out there homeless that has nothing to do with the race? But again, I'm just saying when we come to health equity, it's important to look at it in a broader way that it has nothing to do with race or gender.
So I see it differently, but that's okay. That's been the experience that we have in our work, that unfortunately, sometimes, depending on the race or the ethnicity or the gender, some people have a better opportunity of getting resources and services than others because of that determinant for them.
Okay,
I never denied that.
yeah.
All right,
and so-
awesome. Thank you.
Yeah, there's some agreement there, but some different views, which is why we're talking about this, so we can kind of capture all of that. And I'm sorry we kept you waiting. Andy, please speak to us.
Hi, everyone. Andy Hessian, Endowment for Health. I think anything that I was going to say, Bobby said a lot better. I completely agree with the points that you brought up. And I just wanted to also raise, just in bringing to the forefront the inequities that folks are facing based on the social factors that they're experiencing, was the great work of the Community Engagement Committee and the formation of the SHA-SHIP, and that really connected with folks who are experiencing our healthcare system differently because of the identities that they bring forward. And just, I think there were some great learnings there. So I just wanted to bring that to the forefront as well.
Wow, thank you. And that's on the list for us to really think about in terms of, one of the work groups is the engagement work group. Lots of people have been mentioning that and championing that. All right, this is a wonderful discussion. The other thing that came up, in terms of the spreadsheets folks were working on, in terms of our interviews, is there are some very specific populations that are, you know, without a voice. Having a hard time in terms of inequity, and certainly seniors have come up, and Ed has mentioned that. Disabled individuals has come up as a gender population, homelessness has come up, those battling addiction
That's it.
has come up. Those folks that, are, you know, battling chronic disease that have a lot of stigma, addiction and mental health issues. So there are these vulnerable and special populations also. So there are lots of different lenses to inequity, based on the group. So I wanted to share that if no one has their hands up that wants to talk about those specific populations. So does anyone want to add something in addition to this? Sorry, don't move your feet, please.
Sure.
Okay, sorry, we're doing a safety record here. Thank you. Okay.
Thanks.
So anyone else want to add to this? Okay, and if you would like to, oh, yes, please, go ahead, Tori.
I have a little bit of feedback about maybe the level that we're thinking at. I feel like a lot of the work of the New Hampshire Public Health Association is around, we do have an equity task force that came out of COVID's kind of need to consider some of these differences in the experience different populations we're having. So I'm thinking about if the role of the discussion with regard to the state's health improvement plan, is it about addressing specific inequities, or is it about addressing and identifying a process or a plan to assess equity? Because it feels like those are two different things. If we're speaking about, here are all of the inequities we need to be mindful of, that's a big lift. If it's about, here are recommendations or suggestions or a process or a plan for how to apply equity thinking to whatever size conversation you're having. You know, I think about Bobby's points and Ali's points that you're assessing someone's risk of not having the same access or outcomes based on in situ, where they are, who they are, what is going on with them personally with potential disadvantages. And what we often find are inequities in the system.
Yes.
Where are the system's problems with communicating and exchanging information? You know, so I feel like they're almost two different conversations, and it may be that I'm new to this space, and I appreciate everyone's indulgence in kind of helping me better understand, is the goal of this group's work to address the specific inequities in a specific place and time, or, and maybe it's both, but I think it's an or, talk about how as a system, we're not doing a great job of figuring out where are the inefficiencies in communicating and exchanging information.
Yeah.
Because when we talk about all of the reasons people have, we can fix or not fix homelessness, but if we can't communicate about someone's homelessness state, then we aren't ever going to really understand if we've made their experience more or less equitable. So it's, yeah, homelessness is a risk, but our inability to communicate about it, I feel, is a bigger risk
Yes.
in exchange
Very good.
information.
And I have to say that the way the legislation is written, and again, I'm not a lawyer, but I think we have it memorized at this point, is that there is this sort of, there is an action part and there is an advisory part where they can make recommendations to the legislature. They can also make recommendations to the governor. And they can indeed sort of dig deeper into things in terms of recommending, rule changes, in terms of community engagement. So the different levels from individual communities. So there are things in there. So that is a wonderful question, and I would defer that question to the equity work group, and that'll be one of the work groups, is to focus on equity. But Tori, what's your vote? What would have the most impact from your perspective, if I may ask?
A systems conversation about what are the barriers to exchanging information and communication.
Go ahead, Ruben.
Those have to be necessarily mutually exclusive, because I just wanted to make sure my memory was accurate. I believe the previous iteration of the plan discusses inequities, depends on what level. I would potentially agree that if we're going to look at things at a very granular level, every data point, the race, ethnic disparities, or section gender minority based disparities onto the list at granular and geographic levels, that may preclude looking at other things we might not be able to, but pulling back at a medium high level, you may be able to do both things. How do you communicate to stakeholder discussion and still identify areas that inequity does exist and that you'd want to be able to communicate about, because certain ones requires certain different types of communication and that skill sets and new ones.
Good point, Bobby. We're gonna have to move on with the agenda. I'm sorry, did you want to add?
Well, I was just thinking
Yeah.
about, when I think about what Tori says, I mentioned this to my staff, is there's, when I consider what you're saying, I have to look at what's in my, I'm gonna wax Stephen Covey on this one. There's that which in my control. And there's things I can do. Now, as a CEO, there's things I can do within 26 towns within, I live in Bethlehem, so there's certain things I can do because of that. And then there's that next layer of influence. So this, in some senses, this group has an influential component, perhaps especially as it relates to systemic issues, to the degree it requires policy or different sorts of budgetary investments. And then there's that which is beyond my control and perhaps beyond the control of this, and is tantalizing and intriguing and as shiny as it is. That's the noise in the world I think we need to try and avoid. Because we'll spin our wheels in that. It's not my realm of control, it's not my realm of influence. Why don't we even reflect on it? So for me, that's kind of keeps me focused in action to resolve some of the challenges we face. Because I think some of them are systemic. How do we get the preponderance of 1.2 million Granite Staters to think through the lens of equity in what's in their realm of control and influence? Because it's great that we're thinking about it, but we have limited, Dunbar says we only have 150 primary relationships. That doesn't get us very far with 1.3 million people. So back to how do we take this work out into the community? They tell two people, they tell two people. It's that for me is what I think is compelling of what we can do with the communities we serve. I think too long Americans, policymakers have done it to or at people, rather than with people. So I think it's, I mean, Ruben, I think it's both and it depends.
Both ends, yeah.
Well, I think Ollie was mentioning something earlier, talking about a bill, right, that was like, let's get rid of the Department of Equity. It's like, so this council it's a very easy thing for us to say that we're not supporting for the following reasons. So that's one of those things where
Yep.
we can't affect everything, it's impossible, but that's a pretty hyper localized kind of insane thing that needs to happen quickly.
Yep.
Because
And
And
if
if
we
it
had
were-
a quorum, we could do that.
And if it were to happen as a thought experiment, if I choose to work with on equity in my community, are you gonna arrest me? Bring it on. I mean, so even if that were to happen, as tragic as it would be, it doesn't stop my ability or our ability to do what we do with our friends, family members. I'm like, that's a cute virtual signaling of astroturfing for someone. But you didn't really think it would affect my behaviors, did you? It's kind of a silly kind of political naivete. And so, and I have to do those slot experience. I used to be a compliance officer, so I have to dance on the dark side in order to protect it. Anyways, we need to.
So, yeah, so continue to put things in the chat and we'll gather that. And I think this is sort of just the beginning, and we do need to sort of narrow it down depending on where, from maybe both sides of the continuum, and figure out what we can do, because yes, there's things this group absolutely can do. You have some influence and power, and you have a wonderful voice individually and historically as a group. So, so you can certainly embrace that. Okay, let's move on here. Thank you for everyone that has participated in that. That was absolutely very, very helpful. So this is just a quick reminder of where we began last week and what we did on the whiteboard. We're really focusing on health status and health outcomes based on equity. And this, again, this is all through your plan. So this is a little bit of a reminder and a repeat. And all right, so we did initiatives that folks were doing that they were excited about, that were evidence-based. And these were huge, from nutrition and families, transportation, workforce, community collaboration. So there were a lot of wonderful pieces in this. And as we get more information, if you really want to, you're thinking about, learning more about the oral health program in preschool, or supporting parents in the oral health program in preschool, or if you're thinking about, I'm going to pick on Ed again, the wonderful Food for Medicine and Loneliness initiative that he is using, that other FQHCs or community health centers could access through HRSA or NIH funding for that. If people want to get together about any of these things to learn more about them, we'll support that in a separate forum and whatever. So people can learn from one another, because it's interesting that, again, everything is local. Folks are making progress, have good things, and we definitely want to share them. So I'll just say that, and we're still getting more input on that. And then I want to get to our other discussion for today, which is we focused on in the whiteboard exercise inequitable access and addressing gaps. And some things got very, very clear. It came from multiple sources and they got better defined in these 5 areas. So I'm just going to say a little bit about them, and then the folks who really worked on this and discussed this, if they could step up and say more about that, because these aren't my issues. These are things that were brought up. And this really fits into inequity. And this is one thing that the measurement group will look at. Disaggregated data. Part of the issue in New Hampshire and other little states is they're looking at data as a whole, and wow, they look great on paper, New Hampshire. I'm joking. But if you break it down by very specific groups, then you can see where the issues are. So that came up, the ability for disaggregated data. Efficacy came up a lot, meaning we're doing all these things, we've been doing them for decades, but they're not working. Who is monitoring program outcome? Who is monitoring initiatives? So this was a theme in talking with folks. Housing is right up there, and lots of interesting ideas in terms of the housing part and what can happen there. And then the closed loop referral. Some folks are very, concerned about the barriers and potential burden to the workforce and the implementation of Unite Us. And I know folks are working on that. I know this has been a Medicaid initiative, but some folks are concerned about this requirement and it being heavy lift and how that's going to burden the folks who are doing all the work, the folks on the front lines. And then another big piece was workforce innovation, really using key people to reach these vulnerable and marginalized populations, like community health workers. We just did an expansion there, fabulous. The peer recovery coaches, mobile integrated health, which is EMS. So anyhow, so those are the areas that have come up for discussion, and there may be other areas. because the list is big. But I'll stop here and see if folks who are more intimately involved with these issues, because I can't speak really about them, who would like to say something about them.
Anybody online, since we often start with you last?
So, it's Bobby. Oh, sorry. Greg has his hand up. I'll put my hand up.
Bobby,
Greg,
go
do
ahead. Bobby, go ahead.
No, all right, Bobby first. Okay, what a gentleman. Go ahead, Bobby.
Thanks, Greg. So I'll just speak to the utilization of the paraprofessionals. And so it's a great opportunity in our workforce to include community health workers, doulas, and peer recovery support workers, CRSWs. It's still the barrier that we're still facing, even when you have, and one of the things that came out of our equity report that we sent to the governor back during COVID was that we needed an army of community health workers. Even when you increase that workforce, if the resources are not there, that they're doing that soft handoff to, because that's what we thought our gap was. The community health workers played an integral role in connecting people to services and resources. And so, I have 10 of them here, and they work very hard, and they spend a lot of time helping increase awareness in populations that have been historically marginalized, right? So now we create all this awareness, and then we get all these folks now ready to take services, but then there's no workforce to provide the services. And so we have to look at the complete picture of the workforce. I'll give an example with the mental health or behavioral health, or even with some of the things that we try to do with housing. They'll get them connected, get all their paperwork done, and then slam, they get to an agency and organization, and they don't have the workforce to move any of that along. And so then we're in a situation where it's like, I thought you guys were supposed to help me. We've done all we can. We can't do any more because the other resources are not there, because the workforce is not there. And so we've been innovative with this, but the other component in addressing some of those gaps, we have to look at some of those other specialized or specialty services that are provided and make sure that that workforce is there as well.
That is excellent. Anyone want to add to the workforce innovation part? It's a really important linkage to populations that are less engaged. It's also been seen as innovative way for workforce in terms of getting more people involved and looking at the division of labor. And so a lot of things have come up on this. So I'm going to go, we have a hands risen here. So we'll go to who is next? With Greg, were you next?
Yeah, and I'll add to what Bobby was saying. I think, this group could have an opportunity to particularly advise New Hampshire Medicaid and Health and Human Services as the payment structure for community health workers and other paraprofessionals come into play. The opening of Medicaid billing opportunities in primary care for community health workers is great. I have a small concern that we will medicalize the community health worker type functions, and recognize that a critical role of that particular type of workforce may also need to be to help people who are not accessing any type of care, or who face significant barriers to walking in the door of a care system to get there. So I think we could be advising, helping to evaluate the effectiveness of the rollout of that billing structure across New Hampshire.
Yeah, wonderful. Greg, thank you. Justin, you're next.
Yeah, just high level stuff. I mean, I agree with
Oh,
all of it.
speak up.
Can you hear me now?
Yeah, maybe using the wrong mic on your computer, maybe like the webcam or something.
Let me see here. Is that better?
Yeah.
All right. Yeah, I agree with all the previous points. You know, I think when we look at EMS, you know, there's a couple of issues. I think when we look at individual populations such as like homelessness, you know, where they're in more of our urban areas, I think one of the things is we have access to resources there. And there's programs established, whereas, you know, in our more rural areas, you know, we don't have access to resources. You know, and part of that is one, EMS in the state is, there's several different delivery methods that range from call volunteer all the way up to career services, as well as municipal based and private. You know, and so there's so many issues with EMS, and how it's funded. There's initiatives that are in progress that's being made currently, but I think we can move forward. You know, there's opportunities here within this group to move forward with some of the various programs such as MIH, which is largely non-funded, other than grants and other generous opportunities within DHHS and chronic disease. And really there is a societal cost to this, and societal cost to EMS in general, that I think with the appropriate backing of this group could move things forward to provide universal access to EMS care throughout the state. Because the expectation of the public, regardless of you know, backgrounds, is that when they call 911 or access 911, they're going to get an ambulance, or they're going to get somebody to provide care until an ambulance gets there. And in some parts of our state, that's 45 minutes, an hour. When you talk about transferring patients from some of our critical access hospitals to a higher level of care, which the likelihood is high when you have somebody that's badly broken or is exacerbated and is very sick, you're talking 3, 4, 8 hours in some cases. You know, we've talked about mental health patients waiting days. So it's such a big mess to tackle, but I am confident that we can with this group, and certainly it can benefit, you know, all of our residents and visitors.
There are a lot of different, this has come up, and who am I'm using someone else's words here, but it's also a national issue. EMS folks have been utilized in many different ways in the community, and in terms of wellness checks at home, in terms of they have many different roles, and that's part of the workforce innovation lens, besides the important and basic things, Justin, that you were talking about, that it definitely fits in this category. Excellent. Anyone else on? Oh, please.
Becky Bryant from Lake Churchill Community Services. You know, I have to kind of just reiterate what Bobby said. I'm short 75 direct support workers right now, 75. We've been running that way for about 5 years now.
Wow.
And we are often the ones that are connecting. So EMS is working with us, and everybody's referring, and particularly in the Lakes region, we have a really tight referral system. But at the end of the day, everything can be set up. Our caseworkers help get Medicaid in place. The programs are there for, we serve elders as well as individuals with disabilities.
Yeah.
The programs are there, the Medicaid's in place. Everybody thinks we're the answer, the end all be all. And we are so underutilizing the CFI waiver, the DD waiver, and the ABD waiver right now. We are leaving money on the table, like in astronomical numbers, because we don't have workforce. So I think that, again, at the root of all of this is workforce. I get that, you know, everything everyone's saying about systems and access, absolutely. But if we don't have the direct service workers, if we don't have the workforce, the boots on the ground, we can't even access the programs we already have. And it is beyond frustrating in our world that we are leaving elders at home, that they're not getting to doctor's appointments and they're not getting their access because we literally just don't have the workers to support them to get them there.
Yep, that is excellent. That's very good. That's a critical issue in this. And folks are, so say a little bit more, anything innovative in terms, or lots of innovative in terms of recruiting workforce, reconsidering salaries, career ladder, any additional pieces that you all been testing?
Career ladder is definitely being worked on in our system, at the federal level, working on a visa program.
Yeah.
We have got.
Oh, well, no, sorry.
You know, there's many days that I've said that I could go out tomorrow and advertise that I'm paying $25 an hour, $30 an hour for direct service workers. We're not gonna get them. We are at a point where it doesn't matter what we're paying. Not that I would not love to pay all of our staff much better, but it does not matter. We cannot just create bodies where they're not. I think you were speaking earlier, you know, our aging population, our aging state. We have to do something about bringing bodies into New Hampshire to do this work.
There you go. There you go. Okay, and folks who are making some comments.
If I
This
could,
is all
one comment was
fabulous.
very astute online of, how did we make the system so complicated? I think that we didn't make the system complicated. It became complicated in the process of making it, that we never go back to review it. When I look at software, if I need an instruction manual and it's a failed piece of software, there's a lack of intuitiveness. And I work in healthcare and I find at times facets of it are not intuitive and are overly complex. And I think that's it's almost like a subcommittee group of, imagine picking a process that you could take Occam's razor to. And you know, how few steps could you get? How low could you go? Could you play processing and budget? Because it's like our legal system that we should have a law that you can't present a new law until you take one off the books. Because no one ever takes one off the books. So when I go home tonight, I have to have someone walk in front of me 30 paces to indicate to the horse riders that I have a vehicle. It's probably stolen. Yeah, but I think it is. I think that is brilliant. Wow, how did we get here with these processes that are just so cumbersome? Sounds like a subcommittee to pick one that you could just be successful with. Maybe some.
There are some absolutely wonderful comments here in the chat, from folks. I don't know if you wanted to add anything from what you put on here, Josh, or Bobby, if you want. Bobby, your story is getting me choked up here. Sheesh. Josh, did you want to add anything more?
I don't think so. I mean, I think I've raised this issue a few times, really just to put some real life experience on the conversation where, you know, as a housing provider, what we see day to day, and it seems as if it's becoming more acute and we're having more and more issues of folks who need services, not able to get them in any sort of steady fashion. At least we're getting sort of little pieces here and there, but it's our property management staff and resident services staff are feeling more and more as if they're having to do work that they're not frankly qualified to do, and they're doing the best they can just to sort of keep peace amongst neighbors in the buildings, but they feel like it's an uphill battle.
Well, this sounds like a work group to me, and I think that very, very important to look at alternatives in terms of pipelines, but you know, not pipelines 10 years from now, but pipelines that can address these things straight away. And I don't know if anyone is having more success than other regions. I don't think so. Okay, all right, so we have another comment in the chat. Okay. All right. So, I'm sorry, Dee, you have your hand up, please.
Yeah, my connection is probably gonna get wonky if I go on camera, but I'm still my same usual self. As we're thinking about this, I hear us talk about career ladders. And one of the things that it's been a while since I've touched on it, but there was some interesting research that talked about building your capacity from within. And I think we think about that and we think that we do that. And yet I'm not sure that we think about taking the individual who may be on the job trained and helping them go through an adult learning based program to get the skills to go to a what would be considered a more professional level. And I'm using the wrong terms, but I think you get the general idea. Is I don't know that we have really looked at that to say there are probably folks because of systemic barriers, it wasn't their choice to go maybe where they might see themselves now in the future when they were making a decision out of high school. But are they now making ready to make a different decision, and are there support networks in place? I'm not sure we've looked at that piece, and I may be ignorant of things that are in the hopper, but I thought I would at least offer that up.
Thank you. Thank you, Dee. That's another whole piece. Okay. Oh, boy. Okay. We have just a little more time on this one. And I think that this is an absolutely huge area. And I think that there's room for local, individual, and policy for each one of the buckets that are possible for this council. There's possible things to consider. So I think that this would be a good, very good subgroup. Does anyone want to say anything about efficacy? We've touched a little bit about housing, but we could say more about that, or this closed loop referral. I don't know how many folks are thinking about Unitas and implementing that, have experience with that, or want to say anything about that.
We looked at it prior to the pandemic, then the wheels came off the bus. We're back looking at it, and part of my experience is in adult learning theory and motivational theory, and I completely understand the concerns, and I think the concerns are valid. Anytime there's change, there is trepidation. There's also learning curves. And so what I envisioned with this is fewer sticky notes, phone notes, emails, text, paper faxes on somebody's desk, and something that is more cohesive, that if you went away, I could pick up your work and know where you left off. So it appears to be perhaps a more rational model, and to be able to sit in a single location and make a referral to housing, to WIC, to early childhood development, to elder care in one fell swoop, I think would be nice. It will take some time to build them up. Yeah, so there has to be some patience in doing that, both logistically and the humanity side. People are into the process they currently have, even if it's painful, it's familiar. The saying goes, nobody likes change but a baby with a wet diaper. They cry about it because it's familiar as much as it is uncomfortable. Yeah, so I think it's the right direction. My chagrin is it's not ready for prime time for self-referral. So when I think about some of the workforce challenges, is how far can we push self-advocacy and educate the community writ large, so a neighbor could be more helpful to another neighbor with the right kind of para-knowledge. Because neighbors want to be helpful. They often know where there's gaps. They know who needs a ride, who's home alone, and who's lonely. But they often don't have the resources. They don't know how to act. Not the perfect solution, but they probably could do more, and would like to do more if they had the knowledge. It's some of it is stop, yeah, maybe between that, maybe at some point they need, so I'm excited about Unite Us conceptually, full well realizing that the human side, one at a time, it's gonna take some compassionate care and curation to get people into the groove. You can't run a marathon by showing up tomorrow at the race. You have to actually take some time to do that. So I'm excited about it.
So we have,
Greg's comment a little bit.
oh, we have Bobby and then you, is that okay? Bobby
Okay,
has
I
her
saw
hand.
Greg's comment in the chat.
Yeah, no, and then we'll get to Greg. I think Greg has some really good insight, but Bobby, please, like, we see your hand.
Well, thank you. So one of the things I've had a discussion here with some of the folks that participate on a task force that we have, as to how we could implement the use of Unitas, because when we first learned of it, we thought it would be great because of, again, of that closed loop. You make a referral, you know that it's in there, and then you can see that one of the providers picked it up. We were a couple of years ago able to get a bunch of our organizations signed on to it, but they don't use it. So I wasn't here when you guys had some of the conversations about the challenges, but what I did find last month when I asked, why won't we use Unitas? What I was told was, so there's one grant that came out from DHHS, it's the SOAR grant that requires them to use Unitas. So they are going to use it. The others that don't have a grant requirement, they're not going to. And they talked about all of the other tracking systems that they're using. So even though this particular agency has a SOAR grant, there's 4 other tracking systems that they're using. So now they got to do all of this stuff. So we have the one comment that was in there about why do we make our things so complicated? So we're actually now going to ask folks, because Unitas would be a great tool, but I'm also putting it into HMIS, which is a different tool for tracking for housing to get people prioritized for housing. But that's, you have to use that. And then we have, if you have an EMR, which we have internally, so, and we don't mind doing both. But for some of these other agencies, they've got all of these other things that they have to put in. And so I guess the question would be, how do we simplify things to make certain things communicate so that if it's going into one system, then maybe it's picked up in another? I don't know. I know that there's always some proprietary things that you can't do that. And that's why it has been so hard for us in our state to collect consistent REM data, race and ethnic minority data, because all the tracking things didn't communicate. And so that's been the biggest barrier, but the incentive for this one particular, for the SOAR agencies, is because the grant requires them to use it.
So, Greg, do you want to chime in here? Everyone is loving your comments. And I think it would be good, yeah, if you want to say more or share more.
So Greg Norman from Dartmouth Hitchcock. I'd echo what Bobby just said about sort of duplicating other documentation systems and the burden that puts on staff. And I just wonder in general about Unitas. I think about, there are people who are already in our doors who are getting those referrals and probably have already demonstrated some level of access already. And I think probably Unitas supports that group really well. I think one of our questions we could be asking through the process is, how well is that Unitas platform serving people who have very unstable living situations who would be very hard to follow up with? Like putting a referral out doesn't mean that even an accepting organization has an easy ability to connect or reconnect with that person. So there's still a potential challenge, particularly for people who face probably more barriers than others to these systems.
That's great. You have another?
You had wanted to say something
Yeah,
before.
I just wanted to add kind of with Greg. I'm Monica Leclerc, so Chief Strategy Officer at Huggins Hospital, representing Critical Access Hospital. The Unitas platform actually came about from the Medicaid waiver. We were IDNs all together as a state. The point was to find a product that every single person could use to simplify the process. So I think we're getting back to making things a bit more complicated. And to Greg's point, I think in our area, we were really focused on getting those groups that are helping those marginalized populations, making sure they're on this product. So it's easier for a hospital, we understand these systems, but how can we support our partners that it's harder for them to do that? So I think we need to get back to some of those conversations so we can make sure that we are able to affect change in those areas.
We're looking at what can we make go away.
Yes, exactly.
So if I have this, what now goes away?
Yes, and we
Whether
have to.
it's work or it's the money associated with tracking systems that this can supplant. As I think about this, I know I'm gonna have to invest in an interface. I know the cost of the interface. It's not a cost, it's an investment. Because when I make this investment, the people doing the work will spend more human-facing time and less computer-facing time. But it will take some investment to take the referral tracking system and electronic health record, and this will live like an HIV, is what it's gonna live like.
And interface with the ones that you have,
And
like
when
a
it comes
hospital
back-
can't get rid of its EMR, but it needs to
Yeah.
work, and we have to
Yes.
advocate on behalf of our population to make sure that something like this can come about. We cannot continue to be on disparate systems where we're really not helping anyone. There's no closed loop referral. If we don't try to grow something like this, we're gonna continue to be in the same spot we've always been. And we have to, and as Megan knows, we're gonna have to continue to advocate on the hospital side. It's very complicated. We've put ourselves in a place where privacy is number one. But there are ways to make sure we can connect our patients, and we have to help advocate for that through our privacy networks to say, hey, guys, like, we can do this.
And when they don't, the tracking system, when that person is at risk of falling through the crack, that's when we need to send the human out and go find them. So that they're not, without that tracking system, we don't know who falls through cracks.
Let me go to Anne. She's had her hand up, and please.
Thank you. I just wanted to acknowledge all of these points around closed loop referral and to Greg's point about evaluating the new billing model for the preventative care and Medicaid. And while I don't have all the answers today, I'm definitely going to bring some of that these thoughts to their implementation team for Unite Us. And if there are partners that are in your communities that are saying they're not going to use it, please let us know, because we clearly want, our goal with Unite Us is to get everyone on board, because it won't work regionally or throughout the state unless all the critical clinical providers and social service providers are on board. With that being said, it's not going to be a magic bullet, and in my opinion, systems don't eliminate the need for that personal interaction to help people get into the system, which, Greg, I think that's a really critical point of us tracking. And I'll speak with the implementation team and how we're going to do that tracking, like what barriers are still being illuminated for access to care. And hopefully the state can continue DHHS, I'm sorry, not the state, DHHS can continue to improve our ability to knit together the different programs and waivers. So with the preventative and primary care new model with the MCOs, for those of you who don't know, we're essentially putting the money into the providers that used to go to the MCOs to pay the providers to do comprehensive health screenings, depression screenings, tobacco cessation efforts, care coordination, and there's a lot, hopefully, and for those of you we've met with that work on the hospital side, a lot more money to be put into primary care and preventative care rather than paying the MCOs to do care coordination that may have not been happening the way it was intended to do in the 2.0. And so these billing codes are live, but part of that hope is to look at, with this extra money, perhaps primary care and the hospital clinics can invest that into community health workers or patient navigators or traffic liaisons or any of the different labels that really at the core of it are getting at connecting the individuals to resources. Now that doesn't, to Greg's point, help those who never walk into that primary care door. And primary care is kind of used loosely. It could be the obstetrician, could be a family doc, it could be the obstetrics unit if there is one, and depending on where you live in the state, what have you. So where that person's getting their care. And so hopefully we can look at our waivers with housing or MCO preventative care billing, the closed loop, and continuing to kind of like lift up those barriers and gaps and then find solutions to them along the way. It won't happen overnight, obviously, but I'd love to continue to hear feedback if you're getting resistance in the communities, because we have our vendors for, point click care as well as Unite Us, and want to ensure that we're getting the most value out of it. So sorry. And I apologize if you don't understand. I know I'm talking really fast, but.
So Anne, is there a work group or a network here, or should we just post your personal number everywhere? So what, I'm just joking, we won't do that. But where does all this, is there a coordinating group? It came up in this group and, we want to stay in our lane. Where is this base so that folks can move forward, hear other ideas, or, because it is, obviously it's important. It's part of your work.
We have, I'd be happy for anyone in this group to just reach out directly to me and I can connect you. Many of you know Jenny O'Higgins. She's part of leading the implementation team for the Unite Us, the Care Connections, we're calling it New Hampshire Care Connections. But you can reach out to me if you have questions about the Medicaid primary care codes, and you can reach out to me as well, and we'll connect you to the right people. But we have internal work groups on all of these, so.
Excellent, very, very good.
So, and it seems like there's a big hole with private for-profit hospitals joining the ranks of either point-click care or closed-loop referrals. So when HCA comes to Manchester, let's say, or takes over the Seacoast area, how are we gonna work with hospitals that the state doesn't have much control over? Not you personally, nobody has control over them apparently. So I don't know how we affect that for our patients.
Right. And I don't have a solid answer today, but we're continuing to work on that. So we'll circle back.
And who's responsible at the state? Is that the Attorney General's office that this entity may come into the state? They do that approval, right?
I'm sorry, who has
So
the,
I was thinking that when anybody, we call it HCA, but anybody comes into the state and they want a merger acquisition, it has to go through the Attorney General's office, fair? Yes.
yeah,
Well, that sounds like a beautiful opportunity, put a contingency on that merger acquisition. And one of the contingencies may be a will statement, not a shall or may, but you will be using this if you're coming into our state. Here's some of the contingencies by which, so I think that may be the opportunity. Provide some motivational oversight. Once that's approved, then the motivation's gone. You know, so it has to be on the front end because they have a what's in it for them. They want to come to the state, whoever the they are. And I still struggle with Hayek Friedman's economics and healthcare. I can't square them. I would encourage you to read. I'd read Friedman, not Hayek. Hayek's a lost cause.
So I want to point out something here. If we had a quorum, Ed could make a motion. There could be a second motion, and then we could then make a recommendation based on this wonderful group that does indeed have influence to the Attorney General, to the legislative bodies, to the governor. You could do this, and you have the justification.
So I have a workaround.
Thank you, Ed.
Ann, could you do me a favor? Can you send me the email to the Attorney General who will be reviewing that request?
The
If I can-
public comment period closed
No,
on
I'm not
November
interested in
1st.
public comment. I'm interested in actually a conversation.
Oh, okay.
Yeah.
It's the charitable
one.
trust unit,
Hi,
Ed.
this is Alexandra Cisnowski. I'm Assistant Attorney General at the
Thank you.
AG's office. So I'm also responsible for this review as well as the Charitable Trust Department. So if you would like to email me, I'm happy to set up a call.
Excellent. See, we have the right people in the room. This is wonderful.
See, the excellent.
People from away have to remember, this is our state.
Yeah.
And we have a responsibility to protect our residents.
Yeah.
And they need to be a good guest when they come to our state.
And HCA has a very long reputation and increasing pay. I mean, there are a lot of things about this particular organization also.
As a traditional Vermonter, being upside down, I feel really close to you though, so even though it's not my state, I feel close.
Oh,
Yeah, thanks, Alexander.
That's great. Very good. Okay, we're gonna move on, but we are not letting go of these issues. I think this has been really helpful. If I have left someone out, I do not mean to do that. So we'll get back to you in the chat if there's a question or to reach out again. Tori, you had an excellent point. So do you want to say something about it regarding I'm sorry, it's just really good what you wrote.
Yeah, I think it's kind of what I've included in there is that I think we're missing an opportunity to look at where the gaps really are. I think asking hospitals to use the tool and requiring it as part of a contract is a great conceptual conversation, but how much workforce do we need to ensure that they actually do it? And that the way they do it is effective.
Exactly.
Because right now we have designated receiving hospitals who aren't making referrals to CTI teams at community mental health centers because they're just not doing it. They're just not doing it. And the rule is that you can't do it retroactively. So that's a missed opportunity right there do we need new systems or do we just need to stop doing things that aren't working and start doing things that are? And I think the closed loop referral is a great tool, but the language is not necessarily what I think everybody understands it to be. We can send paper, text, electronic referral information. The issue is what happens to that when it gets to the receiver. And is there a, and I speak from a facilitator of 3 community care teams in the Seacoast where you really don't need care coordination for the vast majority of the population. You do need it for a very small portion of the population. And this won't change their outcomes or experiences. It has the potential to complicate it. We can prevent that, but the way you implement it matters. And I think not including the folks that aren't reimbursed by Medicaid is the wrong decision. I think, figuring out, when we looked at it with the IDNs, it was through alternative payment models and value-based reimbursement. And that's a data question. And we can't do that because we don't have enough data. So instead, we're going to just make more roles and positions at the organizations like healthcare providers who can get paid by Medicaid, but the clients don't see them anymore often. And they still see the social service providers a couple times a week. They see the providers a couple times a year, maybe, and it's only half of the adults on Medicaid who get a PCP appointment within the previous 12 months. So that's my concern about the root cause that came up at last month's meeting. Are we having those conversations and how are we doing it? And who's responsible for and accountable to that?
Yeah.
I feel like we're making this third go around with a closed loop referral system and we're just not where we could be.
Yeah, that theme of efficacy, and that really comes up. All right, we're putting this all together. We're going to be back in contact. This needs a little deeper dive, and then we have some some people working very hard at the state level and with the Attorney General's office. See, this group, fabulous in terms of depth and understanding and in terms of your ability to improve things in the state. Okay, so we're gonna go not through all of this, so we're gonna get right to public comment. Go ahead, Ed.
So I do not know if there's anybody here from the public. If there is, I welcome you, as I did when we began. If there's interest in any comments at this point in time, we thoroughly enjoyed it. You could either put your hand up or put it in chat. So have at it if there's here, you're interested in hearing your voice.
I can check one thing from the public with this conference. Nothing else on a Monday
Like they
morning,
have
I guess.
nothing else to do, right?
Yes, I'm
Okay.
sitting on that public health.
Yeah.
It would be an interesting concept. I mean, how would we have to be such that the public would want to be here? Is it an interesting question?
Yeah, I don't know. Well, that's something to think about though, because it's part of what's
I still
required.
think of how do
Yeah,
you, how do you
It's like
take,
an old tradition. You gotta have time for public. We got no public.
well,
It
and
is.
maybe we need to take it to the public. Maybe it's really, how do you take the ship out in the community?
We've got to hit the road.
I think we have to make sure we're asking reasonable questions.
Exactly. This is a
Asking
different
someone
level.
without the background or history or experience to inform some of these questions is an exercise to aggravation for everybody.
Yeah.
I think there's great ways folks can give us feedback about experiences and stories, but
See, I'm less interested in feedback. I want action. I want to engage them in an act of addressing food security in their local community.
Yeah.
I guess I'm not sure that, is that a role of this group?
Oh, I'm gonna take it personally on as a role. I'm gonna take this ship. I'm gonna take it out in the community and do something with it.
So I think if you
Because I'm
took
not
it to New
patient.
Hampshire Hunger Solutions, they would
I work
welcome you
with
with
them.
open
Yes.
arms.
Yes,
They
they
would
do.
love to
Excellent.
see you coming.
Yeah.
That energy is fantastic.
I'm working with them we have a portable food teaching kitchen. That in the end of 3 years, there'll be 5 from 25 from Plymouth, Winsville to the Canadian border. I'm the kid with ADD who's impatient to wait for committees to act. I just act and ask for forgiveness later.
And on
Probably should have had a stump speech before we did nominations.
Oh, yes.
My first trip to the principal's
Okay.
office was in second.
Okay, sounds good.
I left exonerated.
So we're gonna move on from public comments to, I think we're gonna quickly, so we can get done on time. The next steps, The evaluation link is in the chat. Please do that. We already talked about slides and minutes will be sent out. There'll be a survey coming out. I know we said this before, but then we got sort of clogged a little bit for the in-person meeting so that folks can start moving on things and taking some action. We're going to continue to reach out to you. Not that we want to become nags, but we need to engage. It's a big group. There are 40 of you. They're wonderfully deep, talented people. We need to reach out to you and kind of bring that all together. We'll be sending out another email for volunteering for the subgroups. We came up with several others today. So that would be great. It can be anyone, as Ed said. It could be a member of your staff. It could be anyone from the community. It could be another coalition. We can really, put that together so we can get to a place and then bring those recommendations here. And our next two meetings are Monday, December 16th. I can't believe that. And then in 2025, our first will be on January 13th. All right, any closing comments? Ed?
I don't have a.
Oh, I'm sorry.
I just want to say, when it comes to the workforce innovation part, do we have on this team like resettlement agencies?
No, but that would be a wonderful person to put on the group.
Because I
Yes.
think it's important to have, we have on the Fair Housing Advisory Council and other stuff, where we look at the housing in general, and like Bobby was stating, when it comes to disparity. So resettlement agencies has a lot of individuals that comes here with high skills, but really they don't know where to start. And many of them start in factories because they don't know there is something out there that can help us create this workforce and workforce innovation that we are talking about.
Thank you.
And then the faith groups as well, I think they need a representative here so that they can share those in the respective communities and what is happening. Many of our communities members are working on direct support where they are earning maybe $16, $17 an hour. I just heard you talking about $25, $30 an hour. So I think there is some work that needs to be done in the engagement aspect of it.
Great.
Thank you.
All right.
All right, well, I think people are starting to head off to their next meeting. So thank you, everybody. We will see you next time.
Yeah, next month. Thank you,
Appreciate it.
everyone. Great.